appreciate it. Okay, we're getting people joining, so we're just going to wait until more people are joining, and then we should be fine to start. Okay, I think we're good to start now because we've got some people joining us. Just to introduce myself a little bit, my name is Sally. I'm a trainee pharmacist, but I'm also the graduate officer for BPSA, and I'm really excited today to take this opportunity to run a webinar in prospects of World Antimicrobial Resistance Awareness Week. So, essentially this webinar will be focusing on addressing the issues surrounding antimicrobial resistance and understanding how antimicrobial stewardship could be actioned across healthcare settings, as well as across public sectors as well. We do have a great expert panelist joining us today as well, who will be sharing us their insights, sharing us their stories, and as well as giving us more insights on what antimicrobial stewardship looks like in practice. That's going to be really exciting. Thank you guys for joining us as well. Just a few things before we start. So we've left the chat function. The chat function may be disabled, but you should be able to use the chat function throughout. But you can also write out any questions that you have throughout the webinar. Hopefully the speakers will be happy to answer them, or we also have a Q&A session towards the end as well. So let me just start by inviting our speakers to introduce themselves. Sandra, do you want to start?
Hello, good evening, everybody. Can't see you, but I'm hoping that you'll enjoy tonight. I'm Sandra Martin. I'm an associate professor in pharmacy practice and lead for a postgraduate clinical diploma at the University of Bradford. Thank you.
Lovely. Thank you, Sandra. And Dr. Antonella?
Good evening, everybody. So I'm Antonella Tonner, and I'm a senior lecturer in clinical pharmacy, and I'm up in Robert Gordon University in Aberdeen.
Wonderful. Happy to have you. And Kelly?
Good evening, everybody. Thanks for joining us this evening. My name is Kelly Newby. I'm the lead antimicrobial pharmacist at one of the trusts in Northwest of England.
Lovely. Thank you again, guys, for joining us today. And hopefully a lot of us will have a lot of things to take key takeaways from this webinar. And then we'll, have an opportunity for you to highlight all the sort of new and upcoming and interesting research with regards to antimicrobial resistance as well. Okay, so just to highlight a few learning outcomes, hopefully after this session, you should understand more about the pharmacist's role with regards to maintaining antimicrobial stewardship. You can also gain insights more into the research aspects, as well as identifying key aspects with regards to stewardship, and learn more about the IV to oral switch procedure and the benefits it has to patients. All right, and without further ado, I'm going to pass it on to Sandra to start the presentation.
Okay, thank you. So Sally, I'm just going to check you'll move the slides for me when I ask you to move the slides. That's lovely. I'm not used to that. I'm used to dealing with it myself, so feel very special. So thank you very much, everybody. I was asked just to give you a little bit of an overview of my role with antimicrobial stewardship, and I guess it'll encompass two areas of practice as a sort of an antimicrobial pharmacist, or a pharmacist with a real passion for antimicrobial stewardship. So as I said, I work currently at the University of Bradford. Next slide, Sally. Okay, I think it's always useful to have a little bit of background information. So my first undergraduate degree was at the Welsh School of Pharmacy in Cardiff. I have a master's degree in clinical pharmacy at the University of Bradford, and I also have a postgraduate certificate in independent prescribing, which I'll talk about because my area of practice was around antimicrobials. I'm currently undertaking a Doctor of Education degree, and I'll talk about that later in my presentation because that's around teaching, learning and assessment of AMS for undergraduate pharmacy students. I'm really passionate about teaching and education now. I'm also really proud. I'm an honorary life member of the Welsh School of Pharmacy Association, and I'm also an honorary life member of BPSA. So I feel really honoured and humbled to be speaking at a BPSA event again, because I was a rep for Cardiff, I was the Western Area Coordinator, and I was Public Relations Officer. I'm also Senior Fellow of the Higher Education Academy, which is for kind of university lecturers. And I'm also Chair of a National AMS Pharmacy Education Group that I'll talk about as well. So in terms of my career, I was a pre-reg pharmacist in hospital in Southampton. I worked at Leeds General Hospital for about 10 years in different roles, including a resident pharmacist. I worked in secondary care at Halifax and Huddersfield hospitals, which actually I spent 12 years as a senior antimicrobial pharmacist, which is what I'll focus on tonight. And I also worked a little bit as a GP practice pharmacist, so I've got some primary care experience. And I've worked at 2 universities as an academic lecturer. So I'll talk to you about that as well. Next slide, please, Sally. Okay, so I don't know if you know any of the sort of history, but we're really lucky in the UK now as a whole. We have a lot of specialist antimicrobial pharmacists scattered around the country working in secondary care, in primary care, and in these integrated care boards, and also at strategic level. But if you kind of take a step back historically, in 2000, the Department of Health launched its first sort of white paper from the government into antimicrobial resistance, and antimicrobial resistance was being seen as an increasing problem. In 2001, there's a committee from the House of Lords, SACAR, that set up a specialist advisory committee. And in 2003, the government provided £12 million funding for specialist antimicrobial pharmacists to be employed in all hospitals in the UK over a course of 3 years. And the picture on the right is those of you that know the West Yorkshire area, that's Calderdale and Huddersfield Hospital, that's the Halifax Hospital. So I worked between 2003 and 2015 as a senior antimicrobial pharmacist. So it's on the springboard of that money that was provided by the Department of Health that we now have antimicrobial pharmacist specialists throughout the country. So really grateful. And I always joke about this, that £12 million wasn't my salary. It was across the board for funding pharmacists. Next slide, please, Sally. So as I kind of alluded at the beginning, I'm also an independent prescribing pharmacist. I'm no longer in clinical practice, but my drug of choice, actually, I went for intravenous vancomycin. So those of you that have had a little bit of experience in hospital, it's a hospital-only drug because it's an intravenous antibiotic, although we do sometimes use it for what we call outpatient IV therapy. It's a glycopeptide antibiotic. It's used to treat gram-positive infections, including MRSA. And the reason it's a very special drug is it has what we call a narrow therapeutic range. So we really have to dose patients really carefully in terms of loading doses, in terms of continuing doses and monitoring levels, because it can cause damage to kidneys and also damage to ears and to hearing. So that was my kind of drug of choice as a prescriber. I did that for a couple of years, and it really gave me an insight. I spent years telling junior doctors how to prescribe it, and then I had to actually bite the bullet myself and prescribe it. But I find it really rewarding, and particularly for patients. Next slide, Sally, thank you. And I think, you know, pharmacists have a really key role in AMS, no matter which sector you practice in. So you're here tonight from kind of specialist roles, but I'm going to sort of talk about the kind of 6 key areas that I think we can get involved with. So when I'm teaching about antimicrobial stewardship, and a lot of the documents about it from Department of Health, there are 6 key areas. So they are infection prevention and control, antimicrobials and antimicrobial resistance, the diagnosis of infection and use of antibiotics, antimicrobial prescribing practice, person-centered care, and interprofessional collaborative practice. Next slide, please, Sally. So I could kind of talk to you a little bit about, hopefully to inspire you to think about what you could do, but this is some of the things that I did within those 6 domains when I worked as an antimicrobial pharmacist between 2003 and 2015. So I was part of the infection prevention and control team at the hospital. So I worked really closely with microbiologists, infection control nurses, and colleagues in the hospital. Where I worked, every ward and clinical area had a link infection prevention and control practitioner, and I was actually the practitioner for pharmacy, so I was their link person in addition to being a more specialist role. I spent a lot of time doing education training about things like hand hygiene, and certainly when you go into some of your placements or your pre-reg year, you'll know all about hand hygiene and things, infection control policies when you go onto wards and in hospitals. I got involved in monitoring and audit, and got involved with even things as wacky as the staff flu vaccination campaign, because vaccines are, one of the most important things we have to prevent infection and spread, therefore. Next slide, Sally. So in terms of antimicrobials and antimicrobial resistance, I spend a lot of my job providing education training about antimicrobials, particularly refresher sessions for healthcare staff about how antibiotics work and how antimicrobial resistance develops. I was part of the AMS team, which was led by a consultant microbiologist who was actually my DPP when I did my prescribing course, and also microbiologists. That team met monthly, where we would review our prescribing policies, draft any policies, look at audit work that we'd done, and work out the education and training strategy for healthcare teams. And I also got involved with multidisciplinary meetings, particularly if we unfortunately had significant events like patients develop C. difficile, which is often linked with overuse or inappropriate use of antibiotics in patients. So it's C. diff is a bacteria that can cause, secretes a toxin that causes diarrhea, and is again linked with antibiotic overuse. Next slide, please, Sally. So the next area around AMS that I got involved with was around diagnosing infection and use of antimicrobials. So again, lots of education and training, and this was about appropriate sample taking for culture and sensitivities. So that was around making sure that we did blood cultures for sepsis, MSUs for urine infections, sputum cultures for respiratory tract infections, and making sure that doctors and nurses and ward teams made sure that they order those samples, preferably before they started antibiotics. Lots of education training about why it's important to diagnose the site of infection, and also lots around developing antimicrobial guidelines that reflected local resistance patterns. So certainly in Calderdale and Huddersfield, we couldn't use amoxicillin to treat UTIs because of high resistance of E. coli to that antibiotic. Again, looking at prescribing policies to make sure we use narrow spectrum antibiotics instead of broad spectrum ones. So for example, flucloxacillin, great narrow spectrum, covers Staph aureus for cellulitis rather than carmoxyclav, and nitrofurantoin for a simple lower UTI rather than Cipro, which is broad spectrum. Did lots of work in education training around antibiotic allergy, particularly around penicillin allergy, and also the consequences of being wrongly labelled as penicillin allergic, because often patients would then get less effective antibiotics and ones that were more toxic prescribed as alternatives. So something all pharmacists can do, no matter which scope of practice you're in, whether you're in primary care, secondary care or community, always ask your patient about allergies and document the type of reaction in patient's notes. Next slide, please, Sally. In terms of antimicrobial prescribing practice, Start Smart, then Focus, Quality Improvement Toolkit. I think Kelly's going to talk a little bit more about this when she talks about some of the areas in her slides, but I've put a link to this. This is a kind of quality improvement tool that secondary care uses, and it gives some really good guidance about when you start antibiotics, the so-called Start Smart, and then focusing it for 24 and 48 hours when you review your patients and you review the antibiotics and things. And they've just been updated in August of this year. Next slide, please. So this is the Start Smart, then Focus treatment algorithm, part of that quality improvement tool. So you can see on the left-hand side, find out about what the evidence is for infection in the first place, take a good history from your patient, look at the symptoms and assess. physically examine the patient if you need to, taking any lab results or any cultures and any imaging. Then when you start SMART, you're assessing your patient, what do you think the actual type of infection is? Then you're doing your investigations through the cultures, labs, reporting. Then when you actually start to prescribe, thinking about how urgent is it? Does it need to be prescribed straight away if it's sepsis, for example, or can you watch and wait a little bit? What are your local guidelines say for that suspected type of infection? Check your patient's allergy and any contraindications. And again, that's where as pharmacists we get involved, particularly with drug interactions that patients may be taking, or patients got renal impairment and the drugs are renally excreted, for example. And is it an appropriate choice? Making sure you document what the likely diagnosis is, what the treatment plans are, and then focus it later, 24, 48, 72 hours. The post-prescription review, you've got the cares. So do you cease the antibiotic? Do you amend it? Do you refer to somebody more specialised? Do you extend the course, or do you switch from IV to oral, or do you switch to another antibiotic? So that's the start, SMART, then focus algorithm. Hand in hand with it, there's another algorithm which is around surgical antimicrobial prophylaxis. So if anybody's ever had any surgery, you know that some types of surgery you have to have antibiotics beforehand, some you don't. So if it's what we call clean surgery, so that typically is things like if you're having glaucoma surgery in your eye, you're not crossing any gut barriers or anything that's likely to cause infection, then you don't need any antimicrobial prophylaxis. If you've got clean surgery but you're involving it with an implant, or so an example of that would be if you're having a knee replacement which is clean but you're putting an implant in, you need surgical prophylaxis. Clean contaminated surgery, so that's where you're going to be cutting into your bowels and things as part of the surgical procedure where you've got lots of bacteria, or if you've got what we call contaminated surgery, so again you're actually operating in the bowels and things, then ideally you just give one dose of prophylaxis and you only redose if you've got long procedures under certain conditions. And then on the right hand side, if you've got established infection, then what you do in terms of treating. Next aspect is around person-centered care. So this is about all of us, again, as pharmacists, having open dialogue with our patients when we've prescribed antibiotics or we're dispensing antibiotics. And I always say to the patient, can you tell me why you've been prescribed this antibiotic? And get the patient to tell you in their own words, so you can kind of pitch what sort of level of understanding or what the patient thinks is going on in terms of the infection. So again, as a pharmacist, we should be clinically checking the appropriateness of all antibiotic prescriptions. Remember our patient factors, so co-prescribed medicines, patient's weight, renal function, etc. And then also counsel patients about ensuring adherence, make sure you finish the course, which is the current advice, or what to do if you don't finish the course, in terms of getting rid of the antibiotics, to take any unused ones back to a pharmacy to be destroyed, but not flushing them down the toilet, and certainly not keeping them in a medicines cabinet in the bathroom just in case they need them later. And interprofessional collaborative practice. So every aspect of being a pharmacist, we all work with members of the MDT to promote antimicrobial stewardship. So whether it's microbiologists, infection control staff, primary care staff, other community pharmacists, pharmacists working in primary care and GP surgeries, everybody has a role. You can help shape local services. Where I worked in Calderdale, we had a fantastic outpatient parenteral antibiotic therapy service. This is where patients were given IV antibiotics in their own homes rather than having to go into hospital. Lots around education and training strategy, and then promoting person-centered care at an individual level. Community pharmacy, there's been absolutely loads that's come out and coming out for community pharmacists. So a couple of years ago, one of the community pharmacy sort of incentive schemes was about using an antibiotic checklist, which again, I've put all the links in these slides so you can have a look. It's on the right hand side of the slide. It shows you when you have a patient with an antibiotic, you go through with the checklist so you can confirm what the likely infection is, what the patient understands about that, and what sort of information to give the patient. And it's fascinating. This has been rolled out nationally. I don't know if we have anybody on the call from Huddersfield University, but this was originally an undergraduate pharmacy project from a student at Huddersfield University that is now, been taken on by NHS England and is being used for the part of the community pharmacy contract. which is brilliant. So just think about your own projects and where they might lead. The other thing that's coming out about community pharmacy is there was a message last week, and this is due to come out at the end of January, is about 7 common health conditions about community pharmacists being able to assess patients for things like sore throats, sinusitis, impetigo. So there's a number of kind of simple UTIs where antibiotics may be a potential treatment option under a patient group direction. So that's really exciting for community pharmacists, and there'll be a lot of training and education about that. So, you know, in terms of clinical work, I'm sure Kelly will be coming on to highlight a lot more. I think, you know, it's not just specialist pharmacists. All of us as pharmacists have a role wherever we're working, lots to do around checking prescriptions, checking our patient factors, a lot around education and training, a lot about promoting good hygiene. You know, these hands are really dangerous weapons, so making sure you wash your hands regularly. And also promoting vaccination. And this article here, again, there's a link to it, is a really good one about some roles for community, well, for all pharmacists for AMS. So I've talked to you about kind of the role as a specialist antimicrobial pharmacist in secondary care, but I'm just going to take a couple of moments now just to talk about, you know, the role of an academic pharmacist with an interest in AMS. And this is something that I'm no longer seeing patients, but I am really lucky to be able to teach and deliver and design teaching, learning and assessment for AMS for undergraduate pharmacy students at the University of Bradford. So I currently teach and lead a 10-credit AMS unit, which is in our stage 4 final year students. I've been involved in helping with AMS curriculum development for the whole of the MPharm programme. We've just been through our reaccreditation with the GPHC, so it was part of our sustainability arm of that reaccreditation was around AMS. So I've got oversight of everything that we teach in terms of infection from stage 1 right the way through to stage 4 for the students. And I'm also starting to talk to John Silcock and the team about placement AMS learning as well. So the MPharm degree, all of you will know, is a competency-based curriculum, and AMS spirals through stages 1 to 4 of the curriculum. That's certainly what it does at Bradford. And each time we revisit it, so in year 1, very simple stuff, basic background about microbiology and things, what's bacteria, how do antibiotics work. Stage 2, you know, we do things like a simple case, talk about the role of the pharmacist. Stage 3, more complex cases linking to other comorbidities like respiratory tract kind of teaching or cardiovascular teaching or diabetes teaching. And then in stage 4, we have a kind of a final module where we bring everything together. And I would imagine that each of your schools of pharmacy has got a different path for doing that, but you will be seeing AMS throughout year 1, right the way through to the final year of your undergraduate programme. So as I say, the pharmacy degrees in the UK are based on a competency-based approach. And in 2018, there was development of some national antimicrobial stewardship competencies for UK undergraduate healthcare professional education. And you might see my esteemed colleague, Dr. Tonner, is one of the people listed on this citation. You can just see in the Journal of Hospital Infection. So a series of competencies were developed through kind of questionnaire and surveys between experienced healthcare professionals. And the idea is that it's really important that we just don't randomly teach things. There is some structure to it. So those 6 domains that I showed you at the beginning, they're a core thing throughout these competencies. AMS is a key activity all healthcare professionals need to master, both for patient benefit and also for environmental sustainability through sustainable prescribing. As I say, there's the UK-wide set of consensus-based guidelines, competencies that were launched in 2018. These weren't aimed specifically at pharmacy students, but they are aimed at undergraduate healthcare professionals. And it's about having the skills and knowledge to be able to apply this when you're in practice. So these domains, these competencies have 6 domains and 54 competency statements. So you can see the 6 domains mirror what was seen when in terms of the sort of AMS that I used to work towards when I was a pharmacist. Next slide, please, Sally. So in terms of what I do when I'm working as a lecturer, I'm really passionate about AMS and I want to see it woven through the curriculum. It's obviously quite a lot to get covered. So when should I teach each part of the topic? So things like basic microbiology, structure of a bacteria, you know, that's very much kind of grounding that you need to know in year 1, basic science, right the way through to years 3 and 4, where we start talking about antimicrobial prescribing guidelines and person-centered care, and into professional education with AMS. So you kind of weave it through the program. Because the AmFarm program, you don't need me to tell you, is really busy. I mean, we don't often, some of it's taught alone, but some of it is integrated into other topics. So you may find in your respiratory module, you've got things on asthma and COPD, but you also might cover infection in terms of effective exacerbation of asthma or COPD, for example. Also thinking about how do we teach it? So do we just use lectures? Do we use online media? Do we do little podcasts? Is it lab work, workshops, or case-based discussions? So each way of teaching has a different role. And then, you know, how do we assess it? So do we use multiple choice questions? Do we use OSCEs? Do we use work-based assessment? And I'm also very mindful throughout that everybody, all students have different learning styles, and different topics can be more complex. And there's different sectors of practice and roles that pharmacists, students are ultimately going to go and work in. So you have to make sure you cover all the different roles in different sectors. So on the back of that, I'm now decided to do a PhD about AMS pharmacy education, which is very much linked into how we teach it and how we perceptions of educators and students about teaching, learning and assessment of AMS in undergraduate pharmacy programs. And so I'm using a qualitative approach. So it's not a questionnaire, it's one-to-one semi-structured interviews that I've done with educators, and I'm about to do that with students, hopefully early next year from my sample universities. So on the back of that, I've done some research nationally about these AMS competencies. We set up a national AMS pharmacy education group. So we set up in September 2022. We meet every 2 months online. And the idea is that we share good practice between universities, between national strategic organisations, hopefully influence national AMS education policy for pharmacy degrees, and also do some research into how we teach and students learn about AMS. We've got representatives currently from about 25 out of the 32 schools of pharmacy, which is brilliant. We've got representatives from NHS England, NHS Scotland and NHS Wales, British Society for Antimicrobial Chemotherapy, the Royal Pharmaceutical Society, UK CPA, and also BPSA, because there's no point in us talking about education without having student involvement as well. I feel really passionately about that. So next slide, Sally. So just to summarise finally, journey about being an antibiotic pharmacist has taken me through different stages of practice, but you know, whether that's a specialist pharmacist in practice, whether that's in academia, and whether that's now doing research and teaching or leading a national group. To me, it's all about, you know, working as a team, and everybody has an important role in terms of tackling AMR through AMS. And that's it. Thank you very much for giving me the opportunity to speak tonight, and I'll hand over to the next speaker, so thank you.
Hi, thank you,
Hi
Sandra.
there.
That was really lovely. Oh, sorry, I would just like to introduce Antonella as our next speaker as well. Thank you, Antonella.
Hi, thank you so much. Thank you, Sally. So following on from Sandra, so next slide, please, Sally. That's lovely. So I'll take a slightly different focus. So I'll also describe to you how I kind of came into antimicrobials and antimicrobial stewardship. But I'll focus more onto my involvement in research. And as you see, there's lots of different areas of research and also different ways of doing it. And I'll also focus on research that I've been conducting with my 4th year AmFarm project students. So next slide, please. So I just thought geographically we're right up here. So this is where RGU is. Next slide. And yeah, Aberdeen is absolutely lovely. I'm sure that very few of you have ever been right up here. So Aberdeen is really lovely in the summer, but next slide. Can be quite chaotic in the winter when it decides that it will snow and doesn't really stop. So next slide, please. We've moved to a new campus, which is lovely and shiny and new, and it's right, as you see in the slide here, is right at the top of, it's right by the riverside. So there's plenty of wonderful walks that we can do over there. Next slide, please. And just a little bit about myself. So I started off as a hospital pharmacist in Malta. So I suppose I was a hospital pharmacist for about 10, 12 years there. And I set up clinical pharmacy in Malta, and I worked mainly on respiratory and endocrine and gastric, so basically on the medical wards. And then we moved to the UK. Next slide, please. And my first job in the UK was in Oxford. And in Oxford, I was a surgical admission and discharge pharmacist. And from working in surgery, that is where I developed the interest in antimicrobials, antimicrobial prescribing and stewardship, and particularly, as with Sandra, issues with aspects such as vancomycin dosing. Excuse me. So in particular, so as part of the surgical admission and discharge, we had our maxillofacial patients as well, and they did absolutely wonderful surgery. However, there was some room for improvement in terms of dosing. And that's where I was really interested, particularly because at the time, pharmacist prescribing was also being introduced. So then I moved on to start and complete a PhD. Next slide, please. And that's really where it all started. So my PhD, as seen here, is exploring pharmacist prescribing in hospitals in Scotland with a focus on antimicrobials. And these are a few papers published on the back of the PhD. So in this paper, we're looking at the pharmacist as part of a multidisciplinary antimicrobial program, so a literature review. And then we had the second paper is focusing on the actual primary research, so looking at exploring pharmacists' perception of the feasibility and value of prescribing of antimicrobials. At the time when I did my research, we couldn't really identify a center where pharmacists were really focusing on prescribing of antimicrobials. And because it was independent prescribing hadn't yet come about, pharmacists saw themselves more as prescribing for chronic conditions. So maybe HIV, potentially aspects such as cellulitis. So that was the main outcome of this part of the research. Next slide. And then moving on to some other research that we've done. So this research was part of an MPharm project. And in this research, we wanted to we conducted a cross-sectional survey. So that's cross-sectional, so it's at one point in time, and a survey, so it was questionnaire-driven, of antimicrobial strategies in UK hospitals, so it was a UK-wide. And as you see, we were trying to really look at the profile, look at activities of antimicrobial management teams, the prescribing policies, and the methods of monitoring and feedback that was provided to prescribers. We sent it to all UK NHS hospitals and was equal to 856. As I've described, it was cross-sectional, and we sent a questionnaire. The questionnaire was sent out and we had 273 were returned. So we had around a 33% response rate, which might look low. But in actual fact, if you do look up a like for like, it is around about the expected response rate that you would have. Usually with the general public, the response rate would be maybe about 20% or less. And then in healthcare institutions, you would expect a response rate of around 30%. Next slide, please. So the in the results, I'll just focus on pharmacy input. So as you see, at this stage, so this was in 2011. So looking back on Sandra's comments about when the funding started for specialist antimicrobial pharmacists, as you see, there was already about 95% of the hospitals already had a specialist antimicrobial pharmacist in place. And it acknowledges the important role of the antimicrobial pharmacist. However, in terms of public health pharmacists, we only had 2.7%. So basically only 5 of the hospitals had a public health pharmacist involved. And as we know, aspects such as antimicrobial resistance, stewardship are very much linked to public health and public health campaigns. As you see, so the data was gathered by my 4th-year students at the time. Obviously, they're all acknowledged here, and it really goes to show that good quality data is possible as part of MPharm projects. Next slide. We then moved on to compare this to Ireland. So there was a comparison of 2 surveys. So the survey was repeated in hospitals in Ireland, and the 2 were compared. And in this case, so this is a paper that we published with the comparison. Actually, this is a poster that we presented, but the results have also been published as a full paper. And as we can see, there was at the time, so this was in 2014, published in 2015, and there were about just over 50% of hospitals that responded had a pharmacist as part of their antimicrobial management team. I did do a really quick search and I couldn't identify any updates. So this is probably the last data collected in Ireland. Next slide. We then moved on to community pharmacy, and we're looking at views on the experience of community pharmacy team members. And this was a qualitative study. So in this case, we conducted interviews. So we conducted interviews with members of the community pharmacy team. And we've got our objective here. So we're looking at exploring the views and expectations or experiences rather of community pharmacy teams across Scotland on AMS and on activities related to European Antibiotic Awareness Day and the self-help guide that was used to treat infection. We decided to not have only community pharmacists, but only as in the pharmacists, but all team members. So we interviewed technicians and we interviewed counter assistants as well. The reason being that we thought in terms of a community pharmacy is a team, and the members of the public can come in and really ask for advice at whoever is at the counter as well. So it's obviously important for them to know, for example, when to signpost or when to ask the pharmacist for advice. So yeah, most of the questions in our topic guide focused very much on European Antibiotic Awareness Day, and we asked for awareness of tools, for example, of public health campaigns, so really relatable to this week. And unfortunately, from this study, there was little awareness of this week, so the European and also of European Antibiotic Awareness Day, which is also in this week. The ones who did know about it perceived that it did not have the desired impact on the general public, and they gave us lots of reasons for this, one of them being the fact that the community pharmacies, there are so many posters, so many public health campaigns, that this one just gets lost with all the others. However, most of the people we interviewed were aware of the importance of AMS, though they weren't all familiar with the actual term and its meaning. And hence, I think it's really important to train our undergrads to make sure that you guys as future healthcare professionals are prepared for challenges that you're likely to face in this area. And again, we had 40 students who conducted these interviews. And again, we've got them all acknowledged over here. Next slide. Another study that we conducted was amongst all the university population. So really we were trying to look at the awareness and understanding amongst the university population of the 2016 Community Pharmacy Public Health Campaign, which was aiming at encouraging the responsible use of antibiotics. Next slide, please. And as you see, there was quite a big team of us here. So there was academics, and we also had Jackie from the Scottish Antimicrobial Prescribing Group. She's now moved on to BSAC. And we had Alison, who was from the Association of Scottish Antimicrobial Pharmacists. So it was a team of academics and researchers. Next slide. And so again, this is one of the posters that we presented, and this time it was quantitative. So it was through a survey. And again, the data was collected by our MPharm fourth year students. And next slide, please. And these are actually, sorry, can I have the previous slide? Sorry, Sally. And these are just the results, and just to highlight the fact that let's see, which one is it? It's the third bullet point. As you can see, as expected, I would say, there were a higher proportion of respondents from healthcare related courses that agreed about seeking self-care advice at their local pharmacy if they had symptoms of cough or cold. So as part of this, we asked them a number of questions based on WHO, where we asked whether they thought that, for example, they would seek pharmacy advice if they had a cough or cold. We asked them on aspects such as whether they thought an antibiotic was required in the case of a viral infection. And the results actually were very positive in terms of the fact that the healthcare professionals, so students in healthcare professional backgrounds, tended to do much better in terms of their knowledge and awareness. Next slide. And then we had open questions, and I tried to pick a few, but some of them, so for example, one student answered, I don't know what antibiotics are. So again, things that we might take for granted. And in fact, we did some qualitative work then and took that into account and actually provided a definition of what antibiotics are. So if I knew what it was from the start, so you know, asking questions about antibiotic guardians. Also, we had people saying, I've not heard about this campaign, so the European Antibiotic Awareness Day. Obviously, so they are thinking there is need for improved awareness, creating with messages. So just really interesting as to you know, having this spectrum of pharmacists of students at this point. Next slide, please. Again, so this study, we won second prize at the European Association of Hospital Pharmacists Congress, and it's from 1,000 submissions, and there were only 11 that were shortlisted for prizes. And the reason why I've put this in is, again, it was data collected by the students, it was handled by the students, showing that actually data collected through fourth-year MPharm projects is good, is of good quality, and can also be very impactful. Next slide, please. So currently I also supervise PhD students, and there are PhD students who are researching aspects of antimicrobials. All my students are international students, so we're looking at AMS obviously in different parts of the world. So for example, my student here, Nortan, who actually just submitted and was successful in her Viva. So she looked at the GCC, so the Gulf Corporate Cooperation, and she was focusing mainly on United Arab Emirates. And so while we were conducting her research, the pandemic came along, and therefore a lot of her research ended up focusing on COVID-19 and the impact of COVID-19 on AMS in hospitals. And this is what her research was about. So next slide, please. Again, I've just included these slides. So this was a lovely trip I had to Dubai. So I've included these slides because, again, it was really good, impactful research. Norcan basically won every regional conference that she presented, and she presented the research at various international symposiums. So maybe there's some budding researchers out there who might like to take this forward as a career option as well. Next slide, please. We've also conducted research focusing on patient behaviors. And I believe that looking at patients and or trying to understand how patients behave is really important. And I've just said here, since understanding patient behaviors towards antimicrobials ensures that our interventions are tailored towards them and more likely to be effective. And I've just given an example here. So for example, wanting to explore and understand why people do not wash their hands after using the toilet. So we could stand at the door, we could stand at the toilet door, we could count how many people do not wash their hands. But does it help us to understand behaviors? Not really. And we can culture a palm hand, as you see over here, hand palm, and see which bacteria are growing. But again, does it help us understand behaviors? Not really. But we can take time out and we can speak to people. We can ask what their opinions are, and we can ask why they do not wash their hands. And by understanding that, then as healthcare professionals, we can implement interventions that are likely to have an effect and to be effective and address the patient concerns. Next slide, please. And that is what we try to do here. So as we say, by understanding patient behaviors better, we can better tailor and adapt interventions. So this is what we've done here. So OPAT, so outpatient antimicrobial therapy, is a very important part of antimicrobial stewardship programs. It has numerous advantages. So it's targeted for patients who are in hospital for long periods of time. For example, endocarditis, you could have bone and joint infection. Obviously, the longer the patients stay in hospital, the longer they're likely to gain a healthcare acquired infection. If they're in work, then they cannot go to work. So it makes sense also with the drive of the hospital at home, having a hospital or having services closer to the patient. It makes sense to try and get patients to administer their antibiotics at home. And that is what we were trying to look at over here. So we wanted to look at why patients do not choose to self-administer. We had a really fantastic multidisciplinary team. So we had consultants, nurses, we had the specialist antimicrobial pharmacist, and we had academics. And the driving force behind this project was to determine why the number of patients opting for OPAT here, so in Grampian, were much lower than other health boards. So that's what drove us to conduct this research. Next slide, please. And I'm also involved in running national and international workshops on AMS. So anyone who wants to listen to me, I'm more than happy to. I'm like a broken record speaking about AMS and resistance. But as you can see, every time we have something with AMS at an international level, there's usually really great interest. And as you can see here, we had so many attendees that a lot of people ended up sitting on the floor. Next slide, please. And thank you very much. So I suppose I'll pass you on to Kelly, will I?
Thank you very much, Antonella. Okay, yeah, thank you very much, and thanks everybody for your time this evening. Really tough act to follow there with those presentations from Sandra and Antonella. Thank you. So really good insight there into two antimicrobial pharmacists who've gone into areas of education and research. I guess my contribution this evening is as a practicing antimicrobial pharmacist in a hospital in secondary care. Next slide, please. I've got quite a few animations on mine bit by bit, so you might be doing quite a few clicks here, Sally. So the introduction for what I'm going to cover is I'll give a little introduction to my career pathway and how I work day to day. I'll look at all the different elements of antimicrobial stewardship that you start to get very familiar with. And in particular, I'm going to focus on the IV to oral switch of antibiotics, which is a key theme nationally at the moment. Next slide, please. So I did my master's pharmacy degree from the University of Manchester. I graduated in 2009 and I did my pre-reg in community with Boots. I did it on 2 different sites, again up in Northern England in Lancaster and Kendal. I started with Boots upon qualifying, and then after 3 months I got a job with a local independent pharmacy group, undertaking relief pharmacist roles, maternity cover and managerial roles as well. And for about 7 or 8 years I worked with them. During my time with this pharmacy group, they're really, really supportive of clinical pharmacists and community, and they supported me through my postgraduate diploma, which I did in clinical community pharmacy through the University of Bradford. And I then wanted to gain my independent prescribing qualification through the University of Cumbria. I was able to use this quite well in community pharmacy. I was really fortunate in the demographic of where I'm based. There's quite a bit of deprivation, kind of unequal kind of health outcomes where I am, and the funding came from having a lot of patients and not a lot of GPs. So it was identified that pharmacists have a role to play here in kind of those patients who might need to see a healthcare professional but might not necessarily need a GP appointment. So it's like an extension of the minor ailment scheme that, again, some of you may be familiar with, having come across community pharmacy or done placements in the past. So having done that qualification, I was then able to see patients autonomously, and they come to me for things like eye infections, skin infections, skin irritation, young medicines for children, things like pain relief, and also antibiotics as well. And I think quite a good proportion of my prescribing was antibiotics for fairly simple chest infections or urinary tract infections as well. I always had a formula that I worked to, very kind of strict criteria of what I could treat and what I needed to refer. But the referral pathways are really good, such that had the patient seen me and I felt that they needed, I mean, they need to see a doctor, we could get them in fairly quickly to a nearby practice. After I spent kind of 7 or 8 years in community pharmacy and having done this non-medical prescribing role, the opportunity came up at my local hospital as a role available for an antimicrobial pharmacist. And I felt that this kind of prescribing experience I'd done, kind of dipping my toe into infections, and that kind of area of practice was actually a really good springboard into this kind of role. I didn't have very much hospital experience. I'd only really done placements through university. I say my pre-reg was in community, so it was a big kind of decision for me to make. I really liked the area of community practice where you kind of see your regular patients, and they get to know you, you get to know them, you get to know their background, and you start to see if like any interventions that you make for them, like any advice they ask you, or anything when you do medicines use review, if anything you've done is helping them. And I liked building up that relationship, particularly in the last branch that I worked. It was a very close-knit community, so actually making that jump to hospital was something I really need to think about really, really carefully. However, now having made the switch, I feel like it was a good move that I made for me. It's very, very clinically focused, and I'm getting a lot of satisfaction from the job that I do in different ways. So although I do miss my patients, and I do see some of them, unfortunately, when they do come into hospital, they do recognise me, and we do catch up in that way. So I moved to hospital in 2017, and then 5 years and 2 periods of maternity leave later, there was opportunity then to progress to the lead antimicrobial pharmacist role, which is a split role also in our hospital, with A&E as well on my site. We had a business case put in our trust for improving standards of antimicrobial stewardship and medicines reconciliation. So I oversee both of those areas, although admittedly antimicrobials do take up the majority of my time, but this is the area I really enjoy. This is my passion. In January, I'm planning to start another postgraduate diploma alongside my community one through the University of Edinburgh, and this is in clinical microbiology and infectious diseases. Again, this is kind of underpinning my passion in antimicrobials, which was born from my non-medical prescribing, my community days. I just feel like I want to know more. I want to kind of work closer with the microbiologists and IP teams that we have on the ground, and to support my AMS team and other pharmacists. So this is where I really want to kind of focus my career. So that's what I've been supported to do in a couple of months' time. So, like I said, I'm the lead antimicrobial pharmacist for my trust. I'm really fortunate to have a team of specialist clinical antimicrobial pharmacy technicians and 3 other antimicrobial pharmacists as well. Day to day, the team undertake clinical prescription reviews of patients' antimicrobials on the ward. We focus on IV antimicrobials, patients who prescribe those, which I'll go on to speak more about in a little bit. And they're looking at the appropriateness of the antibiotics prescribed. Is it in line with our empirical guidelines? They look at the dose. Does it need any adjustment for the renal function? Are there any interactions with the prescription? And just kind of have that conversation with the prescriber. Should there be kind of any suggestions for intervention or for review? We very much have it as a two-way process. We are most definitely not the antibiotic police, which is what we were originally coined as, which was quite upsetting. We're there to support and guide and educate on kind of all the principles of AMS and just make sure, we're patient focused, that the patient is getting the most appropriate antibiotic for them at that time. And we can kind of, bring a lot of things together to support that review process with the clinician. Let's click. We're on hand to deal with any queries that we might have around antimicrobials. So teams will get those when they're on the wards. They'll get clinicians or nurses approach them. Then they might want to ask. Other pharmacists might go to them or come to us. Yeah, we're on hand for queries that we can help with. As with any kind of pharmacist role in hospital, we're involved in audit, and ours obviously primarily based on antimicrobials. We've recently done one on antimicrobial prophylaxis and trauma orthopedics, and this was making sure that the patients were receiving the right prophylaxis as per our guidelines. We've got quite a lot of work to do with this because one antibiotic was favoured over another, probably for simplicity. So we've got some work to do with that education and perhaps adapting the guideline to make sure it is still up to date and fit for purpose, depending on our sensitivity data. We've also done one where we don't have guidelines in place at the moment for things like ENT and MaxFax specialities. And we've got quite a wide range of prescribing happening in those specialities, and pharmacists aren't really sure kind of if their antibiotics are appropriate or not. We see a lot of broad spectrum use, and again, kind of to support that, actually, is it appropriate or could we be narrowing it down? So we did a lot of audit work around that, and we're about a point now within the next month or so actually to launch guidelines for ENT, MaxFax and our trust following the results of that audit. We do point prevalence studies, and recently of September and October, there's been the National Point Prevalence Study, which was undertaken. So this involved over 100 trusts nationwide, and point prevalence is about looking at basically a snapshot of one particular day in time on a particular ward, how many patients are on antibiotics. And you can get a little bit more data from it, again, looking at adherence to guidelines. Is it appropriate? Is there a review date? Is there a stop date? All those kind of things related to AMS, and the national one actually went a little bit further, and it started looking at things like hand hygiene, alcohol gel consumption on the wards, that kind of thing as well. So we worked really closely with the infection prevention team to undertake all the requirements of that study, and that was just over a month in time to cover all the wards in our trust. In my role, I chair the Antimicrobial Management Group meeting, which again Sandra referred to in her role as well. So this is a monthly meeting with various clinicians, and we discuss all things from prescribing to things that are going on within the different specialities, any areas of focus we might want to take forward for the next month, and we keep tabs on that in terms of a monthly action tracker, and we report to bodies above us. So we report to the Medicines Management, Drugs and Therapeutics Group, anything drug related, and we also report to the Infection Prevention and Control Committee for our actions, and they hold us responsible for those. I'm a pharmacy representative for a number of other trust meetings, so IPCC and MMDTG that I mentioned just then. Also ad hoc meetings to do with surgical site infections, Clostridium difficile kind of reviews. I'm a pharmacy representative for that, and then I take those actions away that relative to us and ensure that they get completed in time for the next meeting. As any trust has, we have empirical, so best guess antimicrobial guidelines based on kind of the most likely pathogens, our sensitivity patterns locally, and the indication it's being treated and the bug that you're looking to treat. So we have review those on a regular basis, the ones that we have. Like I just mentioned before, we develop new guidelines if there's a need for them, and just make sure that we review them, we promote them, making sure they're accessible to all, so we get the best chance of everybody adhering to them as much as we can, such then that gives the safest care for the patient. Since we came into our formation as a pharmacy AMS team, we deliver and develop training packages and materials for a wide range of clinicians. So we have really good uptake with our junior doctor training programme. We develop about 6 sessions a year now for each of the FY1s and FY2s. And these can encompass things like the basics of antimicrobial stewardship, IV to oral switching, particular prescribing guidance on things like gentamicin and teicoplanin, where there might be monitoring involved. All things like that. We've spread it out also to the non-medical prescribers and the nurse practitioners as well. And now what we're looking at now is also, we've got the kind of bottom down approach for AMS working really, really well. We also need to get the top down approach as well. So how can I put it? Doctors coming out of university are really well versed in principles of AMS and they understand the importance of it. Sometimes clinicians who've been in practice a little while are very keen to kind of do what they've always done because it's worked really, really well, but sometimes things need updating and changing. And it's kind of the senior grades now that we need to have kind of those conversations about, making sure that they are, practicing up to date and it is still appropriate. So that's what we're working on at the moment. Supervised trainee projects, so whether that be trainee pharmacist projects, nursing projects, and also we've got pharmacy technicians undertaking clinical diplomas as well. So we've got projects going on about carbapenemase producing Enterobacter SGO, so CPEs. Another technician did hers on C. diff, and we've got other ones going on again in ED. I linked to with my other role about getting critical meds administered on time, such as Parkinson's disease meds. I must have the responsibility for our trust for implementing the NICE guidelines that are related to antimicrobial. So it's my name on those sheets, making sure that our practice as a trust is in line with all the NICE guidance. One that we've recently updated is the animal and human bites, making sure that our policies in place match those as recommended by NICE. We do a lot of collaborative working, particularly since the team came into force. We didn't have a lot of that going on, but particularly now because, again, as we mentioned previously, AMS spans so many different specialities and departments, you can't avoid it. I think whatever area of practice you're working in, it's really, really important to work together. So when, like I say, the technicians and the pharmacists are on the wards, we have those conversations with clinicians. We also work very, very closely with infection prevention nurses, the infection prevention team as a whole, consultant microbiologists, path lab, microbiology registrars, and junior doctors. We can't do this job alone. We can't work in silo. It has to be a team effort, and this is really, really key to the success of our AMS interventions. We also look at incident reviews and lessons learned. So if there are any incidents that happen in the trust relating to antimicrobials, they come our way, and we review them from the point of not only is there anything that could be done in a systems approach to stop it happening again? So for example, maybe gentamicin was prescribed incorrectly and the patient got too high a dose or the levels got too high. But also, is there anything that we can do as a team to help prevent that from happening again? Anything that we could learn from, perhaps we could have intervened, or any teaching or training that we could do again to minimise the chance of incidents like this happening again. So we are involved with that as well. It's a very multifactorial role, and this is why we need a team to do it. But we're probably about 14 months into fruition. It was kind of last September that everybody came into post, and it's starting to work really, really well. We're starting to see dividends now of the interventions and the presence of our team and what we're making. Next slide, please. So as you're all aware, this week is World Antimicrobial Resistance Awareness Week, and the theme is preventing antimicrobial resistance together. We've seen loads and loads of examples of how this can be done in practice, in research and education, and I'm going to go through some of the main things now about antimicrobial resistance and antimicrobial stewardship that we can do day to day. So a few definitions here that you can find as soon as you put in Google. You get loads of variations, all kind of from a different slant. I picked out some of my favourites that I felt were most apt and were most key and just kind of really got the message about what antimicrobial stewardship is. So about interventions and making sure that you're getting the best drug, the best dose, the best duration, the best route of administration for the patient. I thought was a really good one, just generally about appropriateness as a whole. Antimicrobial stewardship is a key component of a multi directional, multifaceted, multi-everything approach to preventing the emergence of antimicrobial resistance. It's not just one thing. There's so many different components to it. And another one that I really liked was the optimization of clinical outcomes. So making sure the patient has the best outcome from using these drugs, taking into account everything that you can, and making sure that they're getting the best treatment for them. Let's click. These have come out really pale. I can hardly see them on my screen. So we've got, I'll read them out, I can just about see them, and they're not showing up very well on the slides. So the use of empirical antimicrobial guidelines, so best guess guidelines that are kind of taking into account the most likely pathogens, local resistance patterns, and the spectrum of activity of the particular antibiotic to make sure that the indication you've got is going to be the best treated until you start to get things like blood cultures, urine samples back, actually get some targeted approach, starting off with your best guess and the most appropriate one. Usually broad spectrum, and then you can narrow it down once you start to get some results. Using results and bloods and investigations when you get them back, don't just kind of carry on with broad spectrum regardless. We do sometimes see this on the wards where a patient is started empirically on a broad spectrum antibiotic, so Moxiclav, and because the patient is getting better and they're improving, the clinician is reluctant to narrow the spectrum down, which to some extent you can understand. I mean, their priority is their patient and getting them better, but sometimes the best broad spectrum one doesn't necessarily mean it's the most appropriate one, and that's where we can support with that with the advice and guidance to support the most appropriate antibiotic for the patient. Let's click. I think it's allergy status is the next one there. So this is really important. There are an awful lot of projects going on, not just nationwide but worldwide at the moment, about penicillin allergy delabeling. And it was alluded to before. So this is where a patient might have been told that they've got an allergy to penicillin, maybe in their younger years, or been told by somebody else. And actually there's not a lot of evidence for it, or it happened a very long time ago. And now that the patient isn't sure and they've got no real reason to have that allergy status for them. This is where this can be safely investigated and potentially have that label removed, i.e. delabeled. This means that they all now have a wider range of antibiotic options available to them, the beta-lactams, which are often first line in many indications. And there's a lot of projects, protocols, say, up and down the country and also worldwide, to have these allergy labels removed safely from your lower risk patients. Obviously, anybody tends to, when they are allergic to penicillin, they know about it, they remember it, they wear the wristband, they've got an alert band, that kind of thing, when the necklace is the pendants. But a lot of others, patients might think, oh, I was sick, or I had diarrhea last time I had penicillin, I'm allergic to it. Well, that's not the case, and making sure that allergy status is correct can make a difference should they get admitted to hospital very, very poorly, and really need the right antibiotic for them. Using a second line antibiotic may not be as effective, or it may cause side effects, or it might just not be the right one for them. But if that allergy status was correct and they could have beta-lactam first line, it could really make a difference to their outcome. Targeted therapy, I mentioned just before about having make sure you get your blood results and cultures, and making sure you adapt your therapy appropriately, fits into the focus part of the Start Smart focus. Excuse me. Toolkit that was launched by the government. There are things on the other side, but I'm afraid I can't see them. But the slides will be available to you after the webinar, so do feel free to have a look at those. So earlier this year, I think it's February this year, and the government launched a new IV to oral switching decision aid, and this is like a little toolkit, like a little questionnaire almost, and safely step a patient's therapy down, originally prescribed IV antibiotics down to oral. It's quite small there, it's quite hard to read, so I've just summarised it in 5 points on the right. So the first thing is about the timing of the IV antimicrobial review. Preferably within 48 hours, but certainly within 72 hours, a clinician should be reviewing that patient's therapy. Are they getting any better? Have they got any results back? Is the indication or the infection source been identified? And from that review point, they can then start to make some decisions about how to go forward. When we look at the patient's clinical signs and symptoms, are they improving? Are they getting any better? Looking at their NEWS score, which is the National Early Warning Score, is that come down, which is what you want, and that can help to support a decision to step down to oral. You want to be looking at the patient's infection markers, so their CRP, the C-reactive protein, which is like a generalized marker of inflammation. not specific to infection, but can be used as a holistic view when you're deciding if to step a patient down to oral antibiotics or not. Things like your white cell count, your neutrophils, temperature, if any spikes in temperature, all those are trending back to normal. Again, you've got a good shout in stepping a patient down to oral for the remainder of the course. You want to look at the availability or the viability of the enteroral route. So can the patient swallow safely? Are they eating and drinking as normal? Are they absorbing, or have they got any kind of gastroabdopathology, which means that they can't absorb a medicine if they were to take it orally? If all those are yes, then again, you've got another suitable criteria for that they could step down to oral safely. And think about any special considerations. So things like, is the actual antibiotic that you're using available orally, or do you need to make a switch? Oral bioavailability of the drug, could it be switched earlier? So something like levofloxacin or ciprofloxacin have got really good oral bioavailability, even though they're available as IV antibiotics. So actually, if the patient's fulfilling all of the other criteria, there's no reason to leave them on one of those IVs for any longer. Actually, they could go down to oral quite easily and still get the same effect from the drug. This is a tool that came out earlier in the year in the spring, which I'll go into explain about why it came out when it did. And it's the ACE tool. And this is something else that can help to support with stepping someone down to oral. In the middle there, about IV to oral switch, it's everyone's business. It refers to kind of everybody. Everybody has a role as an antimicrobial steward, whether you're a specialist pharmacist, whether you're just starting out, whether you're a trainee, whether you're a member of the public. Actually, everybody can be an antimicrobial steward in some way, shape, or form. So it uses 4 criteria. To again give that kind of clinician a bit of a guide and a bit of reassurance as to if they can maybe step down the patient safely to oral antibiotics. So the patient needs to be afebrile, i.e. not spiking a temperature within the last 24 hours, generally stable, no drops in blood pressure or anything like that. That's your first one. They want to be clinically improving, which is what I mentioned on the last slide about your infection markers improving. Their observations are stable. Actually, overall, as a whole picture, they're doing better. If they're eating and drinking, again, no compromised swallow, no malabsorption, and actually they could safely swallow the tablet or the capsule if you were to give it to them, or the fluid, then that's another one. And the infection that you're trying to treat is not a deep-seated one. So things like bone and joint infections, endocarditis or cardiac infection, sepsis, real kind of Staph aureus bacteremias, which need extended courses of IV antibiotics to get the right penetration, the right levels of drug at the site where it's needed, getting across biofilms, that kind of thing. As long as you're not trying to treat one of those, then again, with that kind of first 48 hours of IV antibiotics, you should be looking at trying to step them down to oral. At the beginning of the year, so in spring, at the start of every financial year in April, there's something called a CQIN that happens, which stands for Commissioning and Quality for Innovation. And this spans very different areas of practice, and there's always one of them, at least one of them, that's related to antimicrobials, antimicrobial stewardship. So the one this year is about IV to oral step down of antibiotics, and that's where that decision aid came from, where the new guidance came from, and where the ACE tool came from. All came together in a pack for trusts to use to try and improve their rates of safe IV to oral switching. On the next couple of slides are some posters that were developed by the UK HSA, which was Public Health England, and the NHS East of England, and I have referenced those at the end. There were quite a few available, and there was 2 in particular that we chose to use in our trust, which we felt really summarised the benefits of IV to oral switching if it's done appropriately and safely. So there's 9 things on this one, and I think all of them are really, really important. IV to oral switching can reduce the incidence of healthcare associated infections. So that's things like C. diff, it's like line infections. If you don't have an IV line in, you can't get a line infection. So the longer that line's in, the more chance you've got that happening. Take it out, get the patient on oral tablets, and you reduce that risk straight away. Reducing the risk of antibiotic-associated diarrhea, so tend to be usually, your IV antibiotics tend to be broader spectrum ones, not always, but they can be. So again, someone on IV for longer has got an increased chance of having antibiotic-associated diarrhea, which may then go on to develop into C. diff. IV to oral switching reduces the risk of perhaps a nurse or a doctor making an error in kind of the preparation of that medicine. If you think about all the steps you've got to dilute, reconstitute, give, flush an IV antibiotic, getting that second check, there's quite a lot of steps to that, and inevitably the more steps you have, the more risk there is of making an error, as opposed to popping out a tablet or a capsule from a pack, getting the second check. There's far fewer steps, so that's a simpler process, means less chance of an error being made. I also found another reference from, again, work I've done around this. It takes around 80 seconds for a nurse on average to administer an oral dose of medicine, but it can take up to 22 minutes for them to administer an IV dose of an antibiotic from start to finish. So again, when you think about how the pressure that nurses are under, as is everybody, but the nurses are under at the moment, freeing up their time to care for their patients, they don't want to be spending unnecessary time making up IV doses. You've got a cost saving. IV doses tend to be more expensive. Again, with all the kind of the giving sets and the flushes and everything else that goes with it, reducing your number of IV doses will save the NHS money as well. There is a financial implication of IV to oral switching too. In terms of sustainability, oral antibiotics have got a lower carbon footprint. Again, if you think of a box of tablets, a top box of oral antibiotics, you can get a lot more of those on any kind of transport compared to, again, usually your bags of, boxes of vials, bags of, ready-made ciprofloxacin, for example, they take up a lot more room. So you're going to get less doses per transport. So that's why the oral antibiotics have got a lower carbon footprint. Think of also the plastic that you use, again, with the giving sets and the plastic in the bags that you would use to reconstitute them. So yeah, definitely a sustainable alternative for using oral. If you talk to any patient, probably the majority of them probably won't want a cannula in or a line in to have their medicine given, and they'd want to take a tablet, majority of the time. And that's where the patient-centered care comes in, that was again spoken to earlier. I mentioned just before about IV to oral switching can free up nursing time to care for the patients. And also if a patient hasn't got a line in, it's going to reduce the amount of time they're in hospital, part and parcel. We do have things now like virtual wards and outpatient antibiotic treatment pathways where patients can receive IV antibiotics in their own home, and that's absolutely fine if that's appropriate for that patient. But for others where it is a more straightforward infection and they don't need that line in, they can be switched to oral and they can be discharged. Again, reducing the number of adverse drug reactions by a significant amount there if they don't have a line in. And again, like I said earlier, most of these IV antibiotics tend to be your broader spectrum ones. So going down to oral and narrowing the spectrum reduces the risk of other infections, resistance. It stops pushing antimicrobials in that direction. Next slide, please. And this was the other poster that we chose to put up on our wards, and I really liked how it gave the different perspectives of everybody involved in a patient's antibiotic treatment. So at the centre of it all, you've got the patient feeling poorly, but they don't like the tube in their arm, they don't want the cannula in, they just want to be discharged and go home and get better. They don't want to have that in for any length of time as much as they can help it. Next along, you've got the nurse who is very conscious of caring for all of her patients as best as she can. But it's, obviously, if the IV antibiotic is prescribed, she needs to administer that. And if actually she could give that patient oral instead of making up the IV doses, she could feel that she could care for her patients better because she wouldn't be as stretched. And that is a very simplistic view, but in terms of IV antibiotics, that is one perspective for her there. You've got the doctor wanting to get their patient home, get them well, help with the kind of the bed pressures. If there's people in A&E waiting for beds, or elsewhere on the wards, they couldn't be an outlier, they could be put back to the specialty ward. They can get the patient home, and they're very conscious of that. And then the healthcare professional in the end, again, possibly a pharmacist, we think, reducing exposure to broad spectrum antibiotics. And then a summary, which I've already on the right, which I covered in the previous slide, it's the same information. So to summarise everything I've gone through there, everyone can be an antimicrobial steward, whatever your sector of practice, whether you're a trainee, whether you've been experienced and have been in practice for many, many years, whether you're a member of the public, whether it's your mum, your dad, your brother, your sister, anybody in any capacity can be an antimicrobial steward of some kind. There are lots of different ways in which we can optimise these drugs, and I've covered quite a few of them tonight. IV to oral switching is one of them. Adherence to empirical guidelines is another. Making sure you get appropriate investigations and review the sensitivities when they come back, making sure the patient's on the right antibiotic for them at the right time. And the benefits of IV to oral, which I've outlined tonight, are significant in terms of the patient, in terms of hospital flow as a whole, in terms of carbon footprint, in terms of cost, and certainly in terms of clinical outcome. They can be huge. This week, with it being World Antimicrobial Resistance Awareness Week, use every opportunity you can to start conversations about AMS. And from the two presentations that we heard earlier, it's really, really assuring that it's not, just a few of us working in silo and trying to, really bang this drum. It is out there. It's taking place internationally, and again, as Antonella mentioned, any kind of forum or webinar or session where this AMS and AMR takes place, there's always a really good uptake. So it is you are in good company. There's a lot of people working to delay this inevitable force of AMR. But this week is a really good way to start a conversation with anybody you can, whether they be in healthcare professional or not. Everybody can do their own little part. Thank you for inviting me to speak this evening. I've been in good company. Thank you so much.
Thank you, Kelly. That was really lovely. And I'd also like to thank all our speakers today as well. I think everyone here could agree with me, but very inspired by the talk today, and inspired by, sort of the, I think you've provided a lot of educational resources and provided a lot of perspectives as well, within the different roles that you've taken over the years, and sort of like, I think you've given us a lot of ideas in which how pharmacy could be really involved and contribute to the efforts with regards to combating antimicrobial resistance. So that was really, really great. And I think I think this is time for a Q&A now as well. So I'd like to open the webinar to anyone who would like to submit any questions. I do have a few questions of my own as well. But before I start, I do just want to thank you again, because honestly, I think as a trainee pharmacist as well, but a lot of us who are listening could also be doing their undergrads, whether they're in year 1 or year 4. I think, throughout our MPharm curriculum, there's a lot of this understanding of the subject surrounding antimicrobial use and implementing stewardship. And it's just amazing to see as well how we can be involved in the future and within our own practice, whether that's sort of leading a team, leading initiatives targeting antimicrobial resistance, whether that's providing, education and training, as a lot of you have done within your career as well, which is really, really amazing. And I think it's the efforts that goes into research as well. And of course, with expanding, the global outreach in which the research you've done could inform, policies, national and international policies. So it's really, really amazing to see that. I think one question that I've had as well, because I did see that you guys have spoken a lot about how, you're working to integrate this subject more into the MPharm curriculum. And now, with the new cohort coming out as prescribing pharmacists, how do you see the ways in which newly qualified pharmacists who could potentially be prescribers, how can they also expand their role within and being antimicrobial stewards themselves, or antimicrobial guardians? Like, how do you think they can access information or learn more about antimicrobial stewardship as prescribers?
Not sure who you want to answer that. Do you want me to make a start with my education hat on? So I was going to say, when you qualify as a pharmacist, there's lots of opportunities for education and training. So there's things like the Centre for Pharmacy Postgraduate Education, so CPPE, have a lot of free courses. The RPS has a lot of webinars and courses. UKCPA does, and also you think you've kind of finished your formal education, but as you can see from the room, the speakers, there's still, Kelly, I'm impressed you're about to start doing a qualification as well, that there's still opportunities for formal learning through postgraduate diplomas. Lovely to see that you're one of our Bradford alumni as well. Opportunities for that. I think also there's lots of opportunities for education and training. So certainly when you look at EAAD and World Antibiotic Awareness, there's the target resources. There's lots of fantastic data with that, and training and webinars, lots of informal training. You may find local networks and things. Certainly community pharmacy, when they launched the sort of community pharmacy contract around AMS, there was some training that was provided as well. So you're never going to be short of opportunities to find that, whether it's informally or formally. In terms of being prescribers, I agree with you. I think brings a different dimension. A couple of us in the room are prescribers of antimicrobials. We're desperately looking at the MPharm degree because it's like trying to shoehorn more in, but there are actually AMS competencies for prescribers that certainly I'm looking at incorporating for our MPharm program when we're adding the bit in about prescribing. So I think there's lots of opportunities and there's lots of materials out there. And I would also say build up your networks, your colleagues, lecturers, When you're working in practice, other experienced pharmacists, other members of the team, find out how other people learn as well. So lots and lots of different routes. There's no shortage, which is great.
Thank you, Sandra. That's wonderful. I don't know if anyone else would like to sort of expand on that as well, but I think you did. I think you did a great job in sort of answering and looking into the perspective of prescribing pharmacists as well. So thank you. And as we're waiting for people to submit their questions, I also have another question. I think this is with regards to sort of and Antonella, I think because your involvement in research is it's really, really inspiring. And I think I myself, I didn't really know as well that pharmacists could be heavily involved in research, and where that could lead you to a different career. Undertaking a PhD is sort of not something that I think many of us may see as a pharmacy prospects, but how would you sort of what advice would you give to pharmacy students who would like to navigate their way around research, specifically within research of antimicrobial stewardship, antimicrobial resistance, and yeah, within that topic in itself?
Yeah, thank you, Sally. I don't think I think a lot of pharmacists are scared of research, and even I mean I think it stems from students and then just kind of builds up. And I think with the opportunity to now accredit, so all credentialing, whether it's advanced pharmacist or consultant pharmacist, research is one of the pillars really of actually being able to accredit. So I would say it doesn't need to be big and fancy. So even like starting off with basic research, even like an audit, just to familiarize yourself with the guidelines, to familiarize yourself with practice, and then taking that further would be a good start. I would also say that if people are in practice, we're always looking, I mean, as an academic, we're always looking for collaborations because things don't happen in silo. So maybe as an academic, I might be more, I might be more proficient in drawing up a research protocol and in choosing the appropriate methodologies. But then it is the practice person who's likely to know where the gap is, for example, or what the priority to be researched is. And that's why we've got, I mean, we're very lucky because we've got really good collaborations, both in community and in hospital. And for example, that's how the OPAT project came along. So the consultants in the hospital really wanted to push it forward and then approached us and said, there's this gap, can we apply for funding? And that's what we did. We got the funding, put together a multidisciplinary team, very multidisciplinary, and we took it forward, and the results were used in a business case. So basically what we found was that it was actually not the patients. So the patients were really keen to self-administer antibiotics, but because we only had one nurse, it was impossible for her to teach all the patients. And therefore it was the results of the study were used as a business case to be able to have posts for other nurses as well in the hospital. So yeah, so we're always looking for collaboration. There's always scope for quality improvement projects, for example, within the hospital. Service bids, maybe, like thinking about where there can be development of a service and then doing it in a really systematic way. So many opportunities for research.
Thank you, Antonella. I think you've you've made it sort of sound less scary to a lot of us, because as you've alluded to, research is one of those things. A lot of MPharm students will only gain exposure to it towards the end of their curriculum. So, but of course, like you said, to do research, you could really expand the impact that you have, not just within your team, but if you sort of carry out your presentations or go overseas and abroad to sort of outline your research to others and expand that global outreach, I think it could really make an impact and inform policies, not just nationally, but internationally as well. I think that's really great that pharmacists could, be involved with that as well. We do have a question coming in. from one of our attendees. So the question outlines, what role do you think a community pharmacist can play in terms of AMS? And this is concerning that there's less opportunity to interact with prescribers with regards to prescribing of antibiotics. So if anyone would like to answer this question, I think I'd like to hear as well from each one of you, because I think you might have different perspectives with regards to this. But I think with community pharmacy, especially because we hear a lot of like the prescribing aspects of antibiotics within a clinical or hospital settings, but not so much in community pharmacy. But with the pharmacy first scheme, that could be changing now, especially with pharmacists taking more prescribing role. So yeah, if you guys would like to.
I think I can maybe make a start. So this is actually a topic that we're exploring with one of my PhD students. So he's actually in Italy, but at the moment we're carrying out a scoping review, where we're looking at roles for community pharmacists. And actually, it's not just about the antibiotic prescribing. There's so many other aspects of of antibiotic prescribing, but not just the prescribing in itself. So I think pharmacists definitely, so all the team definitely has a massive public health campaign role. I think all these people who come in with sore throats, which we know are viral, really big role for the community pharmacists to educate the patients, not raise their expectations that they can go to their GP and get an antibiotic. And obviously with up here prescribing is and Pharmacy First Plus has been on for quite a while. So having that added responsibility, I think that if the pharmacist is an independent prescriber, then they're not going to prescribe antibiotics. There's a lot at the moment on like the near patient testing. So there's a lot of literature from Australia. There've been a few pilots in the UK. So where a patient goes to the pharmacy, and I think Kelly mentioned CRP, so she mentioned the C-reactive protein, but to be able to actually carry out a test in the pharmacy, that would, so if the infection is a viral infection, the CRP is unlikely to be raised. So that way you can also reassure the patient and have that evidence that actually the infection is not actually a bacterial infection, but it's a viral infection and therefore does not require antibiotics. And I suppose the other big one on the back of COVID is vaccination. And this is across Europe. At the moment, there's a big drive for pharmacists to be involved in vaccination. And this, if we prevent the disease in the first place, then we don't need the antibiotic. So again, vaccination is such an important part of stewardship. So I think, yeah, pharmacists even community pharmacists have a huge role to play as well.
Thank you, Antonella. Kelly, would you like to add anything to that as well?
Sure, yeah, I would second that. So although my role is in hospital now, I feel really fortunate to spend a number of years in community pharmacy, and then so that's where I got my interest in antibiotics from. Things like your coughs and colds, where Antonella mentioned there about not having patients expecting antibiotic, but actually educating them actually it's viruses and you can treat them safely yourself at home with the symptomatic remedies that you can get from your community pharmacy. It's really, really key, and often you are that first port of call on the high street or in the retail where people say, I'm poorly, can you help me, basically? And talking it through them, you can identify the best thing that will help for their symptoms, and that education and support for them as well, and reassurance as well goes a long, long way. Kind of going behind the dispensary counter, and if you get a prescription for antibiotics, I think it's probably really a good thing for you to be aware of your guidelines. So things like NICE guidelines that are out there for, say, something like community-acquired pneumonia, things like a 5-day course of amoxicillin is just as effective as a 7-day one. So if you're seeing prescriptions coming through from the GP repeatedly for a 4 weeks course, actually kind of maybe have that conversation with your practice or with your GPs, just to make them aware that actually, in terms of stewardship, that shorter course length is as effective, and you don't need to be exposing patients for antimicrobials for extended periods of time. In community pharmacy and community in general, there's the target toolkit, which can be really, really useful, getting those principles of AMS aware in terms of practice pharmacists, practice staff, and community pharmacy yourselves. So yeah, ultimately, yeah, everybody, as we keep going back to, everybody can be an antimicrobial steward, whatever role, whatever practice that you undertake.
Thank you, Kelly. That's lovely. I don't know if Sandra, if you want to say anything about that as well. Yeah.
I think these guys have probably answered everything I would have said. I was really interested to hear Kelly's perspective as well. It's fascinating to hear a community pharmacist prescriber of antibiotics. I think that's well, as we know, that's a role that's going to be expanding, but definitely, you know, there's so much that pharmacists in all sectors can do. So, yeah.
Thank you, guys. And we have another question. I think that would be the last question because I'm quite aware that we're running a bit over. But the question states, what are your standpoints on delayed antibiotic prescribing?
I don't mind. I'll go for it. Or do you want to go first, Kelly?
Yeah, no, you go for it. You go for it.
Personally, I know studies have shown that actually they are really effective. I think, I'm sure Kelly, you'll be more up to date than me in terms of the number of prescriptions that are then not dispensed. So arguably, you know, and it's great from a safety netting point of view. If you're a mum with a sick toddler on a Friday afternoon and, you know, you're not sure, the GP's not sure, or the pharmacist prescriber's not sure about whether to prescribe antibiotics, delayed antibiotic prescriptions are a great sort of comfort. You know that if you give safeguarding, safety netting advice, if you give lots of advice about self-care, and then a kind of a safety net of the antibiotic prescription if you need it. Lots of studies have shown that a significant proportion are never actually dispensed. So that's again reducing the amount of antibiotics in the environment. So Kelly, I'm sure you're
I would agree. I think that they are really, really useful. It's kind of not kind of jumping to treat too soon when they say there's that uncertainty about, is it a bacterial infection? Actually, is it something that can resolve itself, even if it is a bacterial infection? And, you know, mums with poorly children, you know, I've been there with mine. I think if you get that delayed prescription, even if it's not straight away, I think you get that reassurance that from the doctor that you've been listened to and you have been taken seriously, even though they don't want to jump to treating straight away. And then just kind of giving that infection or that illness time to just run its course, and which, you know, a lot of cases it does, and, you know, 24 hours later your child is bouncing off the ceiling because they're absolutely fine. You didn't have to go and get that bottle of amoxicillin straight off the bat. So yeah, I think they can be quite effective as long as the patient is counselled and reassured appropriately, and they don't just go yes to the GP and then go get it dispensed anyway. So yeah, they do definitely have a role to play.
Okay, thank you, guys. I think that yeah, that will be the end of our webinar today. But again, I just want to thank you for joining us today. Honestly, I've been really inspired by your talk and sort of, you know, the information you've provided, but mainly I think you provided us also with that source of inspiration to really, you know, learn more about antibiotics and not be afraid to sort of try these, to go into these new roles, especially if you're newly qualified as well, and to sort of make connections, network and collaborate with others as well, not being scared to ask the questions and not being scared to sort of take that additional steps, whether that's to, you know, further your understanding of this subject, or taking part in initiatives or programs or campaigns which highlight, you know, ways in which we can tackle antimicrobial resistance as a, you know, within the professional body, but also and also to help within, you know, public health as well. So there's this public health aspect that once, you know, issues like this is tackled, it really does contribute as a whole. But yeah, thank you. That was really a great talk. And as Kelly said before as well, if you've attended, we will be sending these slides to you. So don't worry if you missed anything. And we've also recorded this as well. So this should go up on the BPSA YouTube as well. So, but yeah, thank you guys for joining us today. And I hope you have a great rest of your evening as well.
Thank you very much, everybody, for joining. Really appreciate it. And thanks for inviting us.
Thank you.
Thanks. Bye.
Thanks. Bye-bye, everyone.